E-poster. Ocular pathology, ocular oncology, tumors and orbit and oculoplasty. First is, who is the present? Raja Kannan Durairaj. How much? 3 minutes. 3 minutes. This place is slightly better. It's so hot.
The topic given to me was alveolar rhabdomyosarcoma. Rhabdomyosarcoma is a specific type of sarcoma. These cells are known as rhabdomyoblasts. Frequently manifests in the substantial muscles of the torso and limbs and cells. It is not seen, please note, ladies and gentlemen, above the age of 40 and in the neck and face. A 41-year female presented with a swelling in the left eye, a painful swelling for the past 20 days. Upon examination, the left eye movement was restricted. Biochemical test was done, which showed AST was increased. CT scan showed a pseudotumor. MRI confirmed presence of soft tissue lesion. A biopsy of the orbital mass revealed a malignant tumor. Treatment involved excision of the mass followed by chemotherapy. The histopathologic examination confirmed the diagnosis of malignant round cell tumor. Alveolar rhabdomyosarcoma is also known as monophorous round cell rhabdomyosarcoma, the tumor that differentiates into skeletal muscles. The current case is demonstrated as late onset presentation of an unusual site of presentation. Both imaging modalities help, and actually this case was present because it was above the age of 40. It is very rare and rare to find a rhabdomyosarcoma in the face and in the neck. Thank you, ladies and gentlemen.
Thank you, sir. So next we call upon Dr. Reshika Annamalai Somasundaram for talk on visual outcomes in normal and steeper cornea post LASIK, a comparative study. Can we have the next presenter? So next I call upon Shashwati Sen. She'll be talking about study comparing anterior chamber angle parameters between diabetics and non-diabetics using ASOCT. Okay, if she is also not ready, then we'll move on. I call upon Dr. Kumari Sandhya. Hope your presentation is loaded. Is Dr. Kumari Sandhya here? Can we have Dr. Jimlitha?
Good morning, respected faculty and delegates. I'm Dr. Jimlita from Dr. D.Y. Patil Medical College, Pune, and I will be presenting a case of a 27-year-old male patient who presented to our ophthalmology OPD with a brown-colored mass in the right eye, which was painless and non-progressive in nature. He noticed an increase in size of the mass since the last 8 months, and which was painless, insidious in onset, but without any change in color. He also reported occasional mild discomfort and tearing in the same eye. He was initially he did not disclose us the history of HIV infection, but on proper counseling he told us that he is a known case of HIV infection since the last 8 years and he has been on treatment for the same. We confirmed the status with serology. The remainder of his history was unremarkable with no history of surgery or any ocular trauma or allergies. Now on ocular examination, visual acuity in both the bilaterally was 6/6. In the right eye on anterior segment examination, a mass of size 14 into 10 mm was seen in the nasal bulbar conjunctiva. It was oval in shape, pigmented in color, vascularization was present and it had elevated surface with irregular borders. The rest of the anterior segment examination of the right eye was within normal limits. The anterior segment examination of the left eye was within normal limits and the posterior segment examination of both eye were normal. Now, since strong association of OSSN is seen with HIV, he was planned for a more aggressive approach. He was posted for mass excisional biopsy with no touch technique and the sample we sent for histopathological examination. Now, as you can see, the histopathological specimen of the specimen showed that there were hyperplastic stratified squamous epithelium with nuclei enlargement, mild to moderate anisonucleosis with loss of polarity and few prominent nucleoli. So the histological findings confirm that it was conjunctival intraepithelial neoplasia with one positive margin. He was started on mitomycin eye drops 0.04% 4 times a day for 14 days and asked to follow up, and on follow up he showed no recurrence. As you know, conjunctival pigmentary lesion, it encompasses a wide variety of lesions like nevi, primary acquired melanosis and racial melanosis and melanoma. OSSN includes a spectrum of lesions like mild dysplasia to severe forms like carcinoma in situ and invasive squamous carcinoma. We have to make sure that if a patient has a risk factors like HIV, we have to identify it first and treat it aggressively because sometimes it is the first indicator of HIV infection. The treatment constitutes of topical treatment with mitomycin alone, but surgical removal gives us a dual benefit of definitive diagnosis and eradicating the tumor. We can use chemotherapeutic agents like interferon alpha to beta, mitomycin C and 5-fluorouracil. So HIV screening is of prime importance and we should tailor our management accordingly depending on the presentation. Thank you.
Thank you. Is there any tests that you will consider doing prior to taking the patient for surgery?
Ma'am, tests as in ocular examination or something?
Examination and any investigations for that matter?
No, ma'am. Actually, first of all, we have to check the CD4 count and the viral load of the patient. Then we can go for, if the CD4 count is low, we cannot really go for interferon therapy. We have to go for mitomycin.
In terms of tests for the eye and the lesion. Is there anything that you will consider doing an anterior segment OCT or?
Yes, ma'am. We can do anterior segment OCT because if the signs of OSSN are seen, like if there is a thickened epithelium or abrupt transition, we can know from there also. But in this patient, he typically presented with a pigmentary lesion. There was no cornea involvement. But since he had a history of HIV, that's why we did mass excisional biopsy, and it was a small tumor, less than 4 clock hours. So that's why we went for mass excisional biopsy and then adjuvant chemotherapy along with it.
Thank you.
Thank you, ma'am.
if Dr. Reshmika is ready, can we have you?
So here is the effect of steep cornea on visual outcome after LASIK. Introduction, it was Jose Ibaracqua to introduce it of its first kind. Principle is that power can be changed with just modifying the curvature. Rapid recovery and satisfaction has made this LASIK as a choice of procedure nowadays. Buttonholing of the flaps occurs in steep corneas due to central buckling and also due to increased tissue resistance. Here, efficacy of the LASIK in steep as well as in normal K-value are taken for the study. Materials and methods. Records of 46 patients with K-value more than 47.5 was considered as steep, and those with 42 to 47.5 was considered as normal. They both were matched. The myopes with more than thickness more than 400 microns was taken into the study. Those with known keratoconus, hypermetropes, and those with previous LASIK were excluded from the study. Following parameters are recorded at the before and after the surgery. Surgical procedure, we have no financial interest. MEL 80 excimer system was used we made a flap thickness of 90 to 130 microns with optical zone of 6 mm. Preoperative manifest refraction was taken as a target, and postoperative GAD, teflaxacin and fluoromethanon was given. PAT-T test was used. Postoperative 3 months, efficacy index was noted in both the groups. Discussion. Post-operatively, uncorrected visual acuity was found to be similar in both the normal as well as steep cornea. Conclusion. Conventional LASIK offered a very good outcome even in patients who had steep cornea, which is more than 47.50 at 3 months post-operatively. There was no complication in either group. In steep group, preoperative visual outcome between steep and normal, it was obviously different, whereas post-operatively there was no difference in the post-operative visual outcome in both the groups. Efficacy index was almost same in both the steep as well as normal corneas. This is a preoperative best visual acuity. Preoperatively, it was almost different in both the groups, whereas post-operative outcome, visual outcome was similar in both the groups. There was no difference at all. As well as the efficacy index was not different between both the groups. Thank you.
Thank you, Dr. Reshika.
Is Saraswati Sen present here? Saraswati Sen. She's coming.
Very good morning to all. I'll be presenting my study comparing the anterior chamber angle parameters between diabetics and non-diabetics using the AIOC parameters, and I'll be comparing the duration and severity of diabetes as well. So we know that glaucoma and diabetes are the two chronic diseases which cause irreversible visual damage. So retina, apart from retina, diabetes may affect the anterior segment structures such as cornea, iris, ciliary processes, lens, anterior chamber and posterior chamber as well. So AIOC is a non-contact rapid imaging device that takes cross-sectional images, and it can be used to assess the angle parameters, and the risk of angle closure in patient with diabetes can be assessed. So the study aims to measure the angle structures via AIOC and compare the results between diabetics and non-diabetics. It was a prospective study, covered over 18 months. 200 patients each in the diabetic and non-diabetic groups were taken. A comprehensive ocular examination was done and random blood sugar was noted. AIOC parameters were noted, and the analysis was done using Mann-Whitney test, and a p-value of 0.05 was considered significant. So we see in the demographic parameters, the age group in diabetics is slightly higher than the non-diabetics, but we have more patients in the of duration less than 5 years and mild to moderate NPDR. So on correlating the gonioscopy with duration and severity of diabetes, we found that there was negative correlation. That means that as the duration and severity, grade of retinopathy, duration of diabetes and grades of retinopathy progressed, the angles became narrower and narrower. And on comparison of all the parameters as well, all the difference between the non-diabetics and diabetics in all the important parameters of the angles, like the angle opening distance at 500 and 750 microns, the TISA area at 500 and 750 microns, they all were statistically significant. So were the scleral spur area, the anterior chamber depth, angle, lens vault measurement, and the angle to angle distance. So except the CCT, which was not very different in both the cases, the other parameters were statistically significant. So when we compared the correlation of severity of diabetes with the ASOCT parameters, similarly with severity also and duration also, all the parameters showed statistically significant difference between all the parameters. So we know that several studies have shown that diabetes not only affects the retina but the anterior segment structures of the eye as well. And in corroboration to the present study, several other studies have also found the central corneal thickness to be more in patients with diabetes, and more so when the diabetes is uncontrolled, and this probably is because the hyperglycemic status results in corneal endothelial dysfunction, which results in stromal hydration and thus the increased thickness. And here we also found that the gonioscopic grading, the angle became shallower as the duration and severity of diabetes increased, and this is similar to the findings of Premnath ji et al. And Ong et al. The increase in lens thickness may be attributed to this finding as well. While other studies have compared the angle parameters with respect to HbA1c, which show a longer control, in our study we took the RBS on the day of the examination. And while other studies have compared within various group of diabetic patients between diabetics and non-diabetics, the present study has made comparison of angle structures between both diabetics and non-diabetics, as well as between the different grades of diabetes based on the duration and severity. So I think ASOCT can be combined with gonioscopy and can help in screening and following up of patients with diabetes to assess the risk of angle closure. These are my references. Thank you.
Do you think not matching the age in both the groups would have acted as a confounding factor?
Been a better option, but since the data was a bit skewed, so while doing the analysis, we used the median and the interquartile range instead of the normal like chi-square and t-values comparison.
Sure.
That was the only thing.
Okay, doctor, thank you. So can we have Dr. Vanshika? She'll be talking to us on a rare case of golden hour syndrome.
Good morning everyone. Today I'll discuss about a rare case of golden hair syndrome. It is a disorder of first and second branchial arches. It includes a triad that includes mandibular hypoplasia, ocular and auricular anomalies, and vertebral anomalies. The etiopathogenesis is multifactorial and includes various genetic factors and external factors. In this, patient can present with a variety of features including facial abnormalities, ear, eye abnormalities, vertebral defects, and congenital heart problems. We will discuss a case of 6-year-old girl that presented to her OPD with complaint of some mass in right eye since birth, and there was also improper closure of right eye upper lid. The child was a full-term normal delivery and no maternal illness was present during pregnancy. In a general physical examination, patient was found to be deaf and mute, and there was also alteration in the posture as the shoulder blades were not at same level. CNS was within the normal limit, facial asymmetry was noted. In auricular system, there was congenital deafness, deformed right external ear with preauricular tags was present. In musculoskeletal system, scoliosis was present and there was fusion of cervical vertebra. On ocular examination, visual acuity in right eye was 6/12 and in left eye was 6/9. In right eye, there was grade 1 upper lid coloboma present and a whitish mass with hair follicles present at the inferior limbus measuring 6.5 into 2.5 mm, which was suggestive of limbal dermoid. Fundus examination was normal. In special investigations, B-scan was done, which shows hyperechoic lesion without any internal vascularity, proving again it to be a limbal dermoid. On X-ray skull, AP and lateral view was done to rule out any abnormality in facial bones. OAE and Bera test was done to evaluate for the hearing loss. On 2D echo, we found out that there was perimembranous VSD with a patent foramen ovale with left to right shunt, indicating congenital heart defects. CT spine with 3D reconstruction was done to show thoracic scoliosis with fusion of cervical vertebra, as we can see in these pictures. Golden hair is a rare congenital defect, and the classical features can include ocular anomalies like epidermal or limbal dermoids, ENT features such as preauricular skin tags, hearing losses, facial asymmetry like hemifacial microsomia, where there can be hypoplasia of the mandible, and vertebral anomalies such as scoliosis. The importance of golden hair syndrome lies that it is a multifactorial disease, and its diagnosis is very important, as early diagnosis and management can lead to early treatment, and which can prevent the psychosocial stress and the social stigma which the patient faces in day-to-day life. As in this case, this patient was diagnosed by an ophthalmologist and then referred to various other departments for CT scan and 2D echo, and it can lead to early treatment of congenital heart defects and orthopedic problems. Thank you.
What was done for the eye problems?
Eye
Dermoid
problem, ma'am, we performed ASOCT to look for the depth of the limbal dermoid to remove
Yes.
that. And it was involving whole of the cornea and the conjunctival
Okay.
depth. So we planned it for the removal of that and applying graft over there.
Okay. And for coloboma, what did you do?
Coloboma, ma'am, actually we were not having oculoplasty there, so we referred it to oculoplasty, and they told us that it will be repaired full thickness, repair of lid will be done.
Yeah, yeah. Okay.
Thank you.
This is over now. Now I call upon Nagara Kini M, facial rhabdomyosarcoma.
My presentation is about facing rhabdomyosarcoma, embracing hope beyond diagnosis. Introduction. Orbital rhabdomyosarcoma is the most common orbital malignancy of childhood, with approximately 4 or 5 new cases under the age of 20. Its hallmark symptom, it typically involves rapid development of unilateral proptosis. Herein, we discuss about the presentation and management of this orbital malignancy, embryonal rhabdomyosarcoma, and its successful outcome. Presentation. A 3-year-old male child brought by her mother with complaints of right eye protrusion, progressively increasing in size for past 1 month, with no history of defective vision and pain over the protrusion. On oblique examination, left eye appears to be normal, and right eye shows uncorrected visual acuity was 6/6 partial, and fullness in the upper lid and down and outward protrusion of eyeball with inadequate lid closure, and mild chemosis and exposure keratopathy in interpalpebral area, whereas pupil reacting to both direct and consensual light reflex. EOM is restricted to upward and outward movement. On further proptosis evaluation, right eye shows a Nafziger sign positive and no bruit heard over the swelling. On fundus examination, left eye was normal and right eye shows hyperemic disc, tortuous vessels and choroidal folds. Further investigations of MRI orbit shows iso-intense soft tissue mass lesion in both intraconal and extraconal components extending from the optic canal and displacing the optic nerve inferiorly. Further, the histopathological analysis shows hyperchromatic pleomorphic nuclei with a scanty eosinophilic cytoplasm suggestive of embryonal rhabdomyosarcoma. Immunohistory markers such as MyoD1, myogenin and desmin was positive and NKX2.2 was negative. PET scan revealed no evidence of metabolically active disease elsewhere. Hence, a clinical diagnosis of orbital rhabdomyosarcoma was staged as T1N0M0 was confirmed. Further management, the patient undergone chemotherapy of VAC regimen, vincristine, adriamycin and cyclophosphamide. Since this tumor is highly chemoradiosensitive and the protrusion gradually decreased and a long-term follow-up revealed no evidence of metastasis or recurrence. Post-treatment, both eye and visual acuity is 6/6 partial and EOM was full. Rhabdomyosarcoma is the most common orbital malignancy in children, being head and neck is the most common origin. Incidence is highest in 1 to 4 years, and embryonal rhabdomyosarcoma is the most predominant variation. The diagnosis can be confirmed by further immunohistochemistry markers such as desmin, myogenin and myoglobin. Nevertheless, rhabdomyosarcoma can be lethal and diagnosis requires a high degree of suspicion. The mystery was unraveled with the aid of MRI, histopathological analysis and immunohistochemistry. Conclusion. Orbital rhabdomyosarcoma is one of the few life-threatening diseases that present first to ophthalmologists. Therefore, prompt diagnosis and treatment is life-saving. Hence, knowledge of the clinical, histopathological and radiographic features as well as the recent advances in the management of this entity is essential. Thank you.
What are the prognostic factors, doctor? What are the prognostic factors you consider generally?
Reduction in the size of the tumor. We followed the patient
Presentation? With the presentation?
with the presentation. The lid swelling decreased, ma'am, and also the size of the tumor decreased. Follow-up MRI scan was done. Then they have done the PET scan, ma'am. PET scan revealed no metastasis. So it showed good prognosis.
Thank you, doctor.
Thank you.
I next call upon Dr. Arnab Roy. He'll be talking about an atypical case of anterior orbital neurolemoma mimicking medial angular dermoid.
Good morning. So I will be presenting a case of an anterior orbital neurolemoma mimicking a medial angular dermoid. The orbit, as we know, is a confined space with well-demarcated anatomical landmarks. Cystic lesions of the orbit, such as dermoid cyst or mucoceles, are often encountered, but cystic schwannomas are very rare. A schwannoma happens to be the most common of all peripheral nerve sheath tumors, composed exclusively of Schwann cells. They comprise less than 1% of all orbital tumors. They originate from the ophthalmic division of the trigeminal, most commonly forming within the supraorbital nerve. They are benign, well encapsulated, slow-growing nerve sheath tumors. My case is a woman, 38-year-old, who presented with left superomedial orbital mass, gradually increasing in size for the past 2 months. On examination, there was a 10 mm by 10 mm firm, non-tender mass with smooth surface fixed to underlying bone above medial canthal tendon. The posterior extent was palpable. There was minimal proptosis and Hertel showed 20 mm on the right and 22 mm on the left eye. A provisional diagnosis of an internal angular dermoid was made. Plan of management was CT scan orbit was requested, followed by excision biopsy and histopathology of the mass. This is the clinical picture and the axial view of the CT scan showing an extraconal cystic nodule with well-defined limits. Surgical excision was done using an anterior orbitotomy approach. A retroseptal well-encapsulated cystic lesion was seen above the levator aponeurosis that was not adherent to the periorbita. Mass was completely excised. No recurrence was noted during 6 months follow-up. The clincher was the histopathology, which showed a typical biphasic appearance which had hypercellular antennae A areas as well as hypocellular antennae B areas. Nuclear palisading around the fibrillary processes called verrucae bodies were seen. Therefore, a final diagnosis of an anterior orbital neurolemoma or schwannoma was made. Treatment of these schwannomas essentially is complete surgical excision with the capsule intact. Partial resection can lead to recurrence of the tumor. Since there is no clinical or radiological pathognomic signs of schwannomas, the histopathology is the characteristic finding in these cases, which has antennae A pattern of spindle-shaped cells which are compactly arranged and antennae B cells which are loosely arranged. These are my references. Thank you.
Was there any signs of neurofibromatosis?
No, there were no.
Any family history?
No, there was no family history.
Thank you, doctor.
Now I call upon Divya Bhanu Devarapalli, a case of recurrent pterygium pointing towards pre-malignancy. Divya Bhanu. Okay. Okay. This one, huh? Not there. Shubhankar Suman. Okay, sorry.
Good morning, everyone. My topic for today is a case of recurrent pterygium pointing towards pre-malignancy. So my topic for today is a case of recurrent pterygium pointing towards pre-malignancy. So these are the patient particulars. The patient came with a 52-year female who was a tea plantation worker by occupation. She presented to the OPD with a complaint of redness and swelling in the left eye since 1 month, along with foreign body sensation nasally. There was a history of pterygium excision 6 months back, and no other ocular symptoms or trauma was present. She had a history of 6 months back surgery, Pterygium tissue was excised with a conjunctival autograft. Post-surgery, the granulation tissue was formed at the autograft site, which was excised and wound was covered with surrounding conjunctival tissue. There was no relevant history in the past or any relevant family or personal history. On anterior segment examination, the conjunctiva of the left eye showed congested and swollen mass nasally over excised bed of primary pterygium. The management, the recurrent pterygium was excised and conjunctival limbal autograft was placed at the site of excision. Excised pterygium sample was preserved in the formalin solution and was sent for histopathological examination. The patient was discharged on post-op day 2 with standard treatment and general advice. On histopathological examination, loose fibrous connective tissue with fibrovascular ingrowth was observed. There was also presence of stratified squamous epithelium without keratinization, elastic fiber precursors, abnormal maturation forms. There was increase in number of T lymphocytes, cytokines, growth factors and macrophages. There was also presence of angiogenesis with fibrosis and hyperplastic, dysplastic vacuolated goblet cells. So pterygium was supposed to be a benign conjunctival growth on sclera, but it was observed as inflammatory and pre-malignant lesion as well. In our study, we have shown the histopathology of pterygium consists of numerous inflammatory cells and pre-malignant cells. Also, there is increased T lymphocytes, cytokines, growth factor and macrophages, along with angiogenesis and elastic fiber precursors. Numerous fibroblasts found indicate actinic-induced damage that resulted in formation of abnormal tissue. So conclusively, it can be said that pterygium may also have a pre-malignant potential as it shows altered histopathological features and recurrence. Hence, it needs further study to understand its pre-malignant potential. Thank you.
What are the risk factors for recurrence, doctor?
One could be the UV rays that's the main factor in subhimalayan region mainly. And other is that if we don't put a proper limbal autograft, so it can recur again and again.
Okay, doctor, thank you. So next, can we have Dr. Deepthi Shikha Kamal to talk to us about optic nerve pilocytic astrocytoma in pediatric age groups?
Good morning everyone. I will be presenting here on optic nerve pilocytic astrocytoma in pediatric age group. A brief introduction. Pilocytic astrocytoma is a distinctive subtype of astrocytoma that occurs predominantly in children and adolescents younger than 20 years. Incidence, it decreases with age. Pilocytic astrocytoma is categorized as grade 1 glioma with a good prognosis when it is associated with neurofibroma 1. My case discussion is, this is a case of 8-year-old male with a complaint of diminution of vision in left eye for 1 month. There is no any other significant history of any comorbidity, ocular or head trauma. General physical examination revealed within normal limit. Ocular examination, right eye vision 6/6, left eye PL negative, pupil RAPD in left eye, there is no proptosis. Extraocular movement, right eye free and full, left eye there is limitation in elevation. Fundus showing right eye's disc and macula within normal limit, left there is blurred disc margin and tortuosity of vessels seen. FDT done, which showed SR restriction in left eye. Other cranial nerves were intact. This is the pre-op 9-gaze image showing a limitation in elevation in left eye. Investigations, routine blood investigations were found within normal limit. Contrast enhanced MRI was done and there was left optic nerve which showed fusiform enlargement involving whole intraorbital and intracanalicular segment of left optic nerve including posteromedial aspect of left eyeball. This is the contrast enhanced MRI showing fusiform image of the orbit. Operative procedure was done. Near total excision of the optic nerve glioma was done with the left terional craniotomy and lateral wall of cavernous sinus was reached extradurally. It was graded as a low-grade tumor of optic nerve glioma. Histopathology revealed pilocytic astrocytoma. Immunohistochemistry was done, and there was it was positive for KIAA1549, suggestive of astrocytoma. So impression made is pilocytic astrocytoma, seen as WHO grade 1. This is the post-op picture. which caused iatrogenic ptosis. This is the evulsed optic disc. This is 3 months follow-up showing partially recovered ptosis because of aberrant innervation and mid-dilated pupil. And there was on MRI, it showed a reduction in fusiform dilatation of the optic nerve. Concluding the case, this is a comprehensive ophthalmological examination is crucial in these cases in order to diagnose recurrence of the brain tumor where no other neurological signs are present. Thank you.
Is there any other associated condition with that?
Ma'am, in this case, there was no neurofibroma, but yes, in some cases it is associated, and that also has a better prognosis when it is associated with NF1.
But if surgery is done, it will cause full damage to the optic nerve.
Yes, ma'am, it caused iatrogenic.
Yeah.
Yes, ma'am.
Okay.
Thank you, ma'am.
Next, I call upon Mr. Pradeep, tapeworm with ptosis and proptosis, a rare presentation.
Good morning. Good morning. My topic is tapeworm with ptosis and proptosis, a rare presentation of ocular myocystis. Introduction. Cysticercocellulosa, the larval form of the pork tapeworm tenuisolium, is the causative organism of cysticercosis. Humans are the intermediate hosts in the life cycle. Human cysticercosis occurs by ingesting the eggs of tenuisolium from contaminated food and water. Ocular cysticercosis may be extraocular, in which subconjunctival or orbital tissues, intraocular in vitreous and subretinal spaces and anterior chamber. Case report. A 27-year-old male presented with complaints of right upper eyelid swelling, drooping of eyelid, and pain since 1 month. No diminution of vision, no diplopia. There were 3 episodes of sudden drooping of the right upper eyelid over the past year, which resolved with medications. Patient took ophthalmology consultation elsewhere and was advised topical medication, but recurrence was seen once medications were stopped. He consulted medical hospital with complaints of right eye complete ptosis with lid edema and erythema, where they got the MRI brain orbits done and was diagnosed with right eye intraconal capillary hemangioma. Came to Oculoplasty hospital for further management. On examination, vision in both eye 20/20, color vision 70/17. Extraocular movements were free and full. Hurtles, there was base 120, right eye 21 millimeters and left eye 18 millimeters. Right eye on examination, moderate ptosis present, anterior segment within normal limits, fundus, mild temporal pallor was present, retina also. Left eye, anterior segment within normal limits and fundus also normal limits. Investigations, we had sent for CT brain with orbits with 2 mm cuts, axial, coronal and sagittal section. Blood investigations, complete blood picture, ESR, BTCT, RBS and HIV and HBsAg serology has been sent. CT scan did not show a clear view of the cystic component, so we revisited the previous MRI. An enlarged superior rectus with a hyperintense rim and a hypointense center was noted. Few internal hyperintensities were noted, suggesting scoliosis. With this we come to diagnose with right eye myocystis of the superior rectus muscle. Management we did started on tablet albendazole 400 mg OD and oral steroids for 1 month. The patient was reviewed after 1 month. Vision in both eyes were 20/20. Color vision was normal. No RAPD. Extraocular movements were free and full. On examination, right eye very mild ptosis persisting, improved compared to the last visit, and no proptosis was noted. Conclusion: intermittent ptosis and proptosis with periods of resolution with medications are suggestive of inflammation. The typical cystic appearance within the muscle differentiates it from the non-specific ocular inflammatory diseases. Thank you.
Thank you, doctor. Can we next have upon Dr. Anu Shirawat? She'll be talking to us on a case of pulsating proptosis.
Good morning, everyone. I'll be talking about a case of pulsating proptosis. First of all, I'll tell about carotid cavernous fistula. That is an abnormal connection between cavernous sinus and branches of ICA or ECA, or direct connection between cavernous sinus and ICA. So, presenting the history, this is a history of 60-year-old female resident of UP, homemaker by profession. She presented with redness and swelling of right eye since 2 months with outward protrusion. There was no history other than experiencing redness and swelling in the right eye. The protrusion was insidious in onset, gradually progressive, painless since last 2 months, and was associated with limitation of eye movements. The patient is associated history of holocranial headache. There was history of protrusion of eyeball on bending forwards and on cuffing. The patient has also history of stroke 5 months ago, and she was a non-case of hypertensive and was on tab amlodipine, ecosporin, and atorvastatin. She was of average build, had no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Her systemic examination was within normal limits. On central nervous system examination, there was no focal neurological deficits. All cranial nerve functions were within normal limit except right, third, fourth, fifth, and sixth nerve, and left sixth nerve. Her uncorrected visual acuity was 6/60 on pinhole. It improved to 6/24 in right eye, and on in left eye it was 6/18. Her IOP was within normal limit. Extraocular movements were limited in all gazes in right eye and was limited in abduction in the left eye. In right eye, the conjunctiva had severe chemosis, dilated conjunctival and episcleral vessels. Her pupil was of 4 mm and was sluggish, had sluggish direct and consensual reaction, but there was no RAPD. On fundus examination, it was within normal limits. On orbit and ocular examination, there was axial proptosis. Fullness was noted in both upper lid and lower lid. There were multiple tortuous vessels as seen there with bluish discoloration. There was increase in proptosis on bending forward and Valsalva maneuver, and chemosis was seen. On palpation, multiple dilated vessels were seen. There was no resistance to retropulsion, and finger could be insinuated between the eyeball. On Hertel's examination, there were 4 mm proptosis. On auscultation, a bruit was heard over the lids. On investigation, we could see dilated superior ophthalmic vein. On CE-MRI, on DSA, we could see right direct CCA from internal carotid artery with reflux into dilated superior ophthalmic vein. So our diagnosis was right-sided Barrow's type A carotid cavernous fistula, and her management was done by doing DSA, which revealed direct CCF. The patient was managed by endovascular occlusion of fistula through right percutaneous transfemoral route with coils under GA in interventional radiology department. Thank you.
Thank you, doctor. Next, we call upon Dr. Ashish Gupta, who will be talking to us on a rare case of choroidal hemangioma.
Good morning, judges. The topic of my e-poster is a rare case of choroidal hemangioma treated with plaque brachytherapy. I have no financial disclosure. It's not moving. I have no financial disclosure. Choroidal hemangioma is an uncommon benign vascular tumor of the choroid that can be circumscribed or diffuse. Circumscribed tumors occur sporadically, usually diagnosed between 2nd to 4th decade of life, without any associated local or systemic anomalies. In contrast with diffuse choroidal hemangiomas, which are usually evident at birth and generally occur as a part of Sturge-Weber syndrome. Treatment is needed when it is associated with visual symptoms and exudative retinal detachment. This is a case report on hospital-based retrospective observational descriptive study in which the 45-year-old female which presented to the OPD with chief complaints of progressive diminution of vision in the left eye from 10 years with increased diminution of vision in the left eye since the 1 year. Patient underwent complete ophthalmic examination including visual acuity, slit lamp examination, fundus examination, B-scan, OCT, FFA. The best rated visual acuity in the right eye is 6/6 and in the left eye it was finger counting at 1/2 meter. Pupils were normal in shape, normal reactive in size in both the eyes. Fundus examination showed a large globular around 8x8 disc diameter in size, well-defined orange-red mass situated in the posterior pole involving the fovea with surrounding SRF, suggestive of circumscribed choroidal hemangioma. FFA in the left eye showed mild lacy hyperfluorescence in the early phase, followed by diffuse intense hyperfluorescence that persists in the late phase also. No disc leak and no CNP areas were there. B scan of the left eye showed an acoustically solid dome shaped mass with echogenicity like that of the surrounding choroid and with high internal refractivities on the A scan. This is the patient was referred to higher center for plaque brachytherapy. This is the fundus photograph showing a left eye juxtapapillary circumscribed choroidal hemangioma with surrounding subretinal fluid involving the fovea causing diminution of vision. She was treated with plaque brachytherapy. Around 20 months after the treatment, the lesion has regressed as a placoid scar with no choroidal mass on the OCT and complete resolution of the SRF and gain of visual acuity of 6/6 partial. Recently, radiation in the form of EBRT and episcleral brachytherapy have paved the way for the management of choroidal hemangioma with preservation and improvement of vision. Episcleral plaque brachytherapy is advantageous as it is widely available, ease of handling, and the storage. It is also effective for eyes where other treatment modalities have failed. It treats the tumor from its base, that is closer to the site of the pathology. Therefore, it reduces the amount of anterior segment complications also from the radiotherapy. Cobalt 60, iodine 125, palladium 103, ruthenium 106 are the very radioactive isotopes which have been successfully used with early complete resolution of the SRF, regression of the tumor, and improvement in the vision. The disadvantage is that it requires two surgeries, one for the insertion and one for the removal. CCH is a relatively rare tumor that becomes visually debilitating because of its location on the posterior pole and SRF exudation. The management has evolved with laser photocoagulation to transpapillary thermotherapy, PDT, plaque brachytherapy, EBRT, anti-VEGF injections. Anti-VEGF injections are needed to resolve the macular edema, but it does not act on the underlying pathology, so we have to combine it with other modalities. Plaque brachytherapy still remains a preferred option of treatment because of its ease of administration, minimum collateral damage, and usefulness for a variety of hemangiomas in terms of location and amount of SRF. These are my references. Thank you, ma'am.
Thank you, doctor. For the final presentation, we call upon Dr. Kumari Sandhya to talk to us on a management of a rare case of congenital lower lid entropion.
A very good morning all. I would like to thank AIOS for giving me this opportunity. I, Dr. Kumari Sandhya, here to present a e-poster. The title is Management of Rare Case of Unilateral Congenital Lower Lid Entropion. I would like to start with brief introduction, that is congenital entropion is a rare condition in which there is a lower lid margin rotated inward since birth. This mostly occurs due to disinsertion of the lower lid retractors. Other causes of the lower lid entropion are like posterior lamellar vertical insufficiency or kinking of tarsal plate. My case report is a 18-year girl presented with watering and diminution of vision in the left eye since early childhood. Her best corrected vision is 6/6 in the right eye and 6/18 in the left eye. Intraocular pressure on non-contact tonometry is 18 mm in both eyes. On slit lamp examination, we found that right eye anterior segment findings are within normal limits. Left eye cornea got multiple superficial punctates were there, and rest of the anterior segment finding is within normal limits. Dilated fundus examination was also within normal limit. So a diagnosis of unilateral left eye congenital lower entropion along with dystichiasis is made. So we planned for the medical management. We did epilation of the lashes from lower lid of the left eye. Then we prescribed her lubricating eye drops for frequent instillation and called her after 1 week. On follow-up, her left eye cornea got clear, but small growth of eyelashes were seen in the left lower lid. So a surgical management we planned to under general anesthesia. We did left lower lid pentagonal resection of the tarsal plate with lower lid retractor plication through transcutaneous approach under general anesthesia. This is the post-operative day 1 picture, and this is the post-operative day 15th picture. This is the final post-op follow-up day after the removal of the suture. Post-operatively, after 1 month, we did refraction, and her vision with the glasses improves to 6/6 in the left eye. In the conclusion, I would like to say that the combined surgery, that is pentagonal resection with inferior retractor plication, this got a low recurrence rate and high success rates. That's why we proceeded with that surgery. Timely surgical intervention is case-based and it needs meticulous planning to prevent complications. Thank you.
Why pentagon resection was done? Why is there?
Yes, ma'am. There is a little bit of lid laxity was there.
In 18-year-old?
Yes, ma'am. It was there. That's why we planned for that.
Okay.
Okay. Horizontal lid laxity was there, ma'am.
Okay, thank you.
Okay.